So after the approval of sorafenib in 2007, there were two large unmet needs. One, another drug in frontline, but even greater, what do we do for patients who progress on sorafenib or get no benefit from sorafenib? And for many years, this was felt to be an easy spot for drug development because the control arm was placebo, right? There was nothing approved. But as we saw, as in frontline, it wasn't so easy, and there were numerous failures, initially with ramucirumab, everolimus, brivinib, until the resource study, which was the first positive study in liver cancer for about a decade. And this study evaluated regorafenib, which is a multi-kinase inhibitor, similar to sorafenib, but with some differences. It has a little broader kinase profile, a little more potent. And this study took patients who were on sorafenib and were on it for a minimum period of time, so they were not sorafenib intolerant, but they had tolerated a minimal dose of sorafenib for a minimum period of time. And then at progression, and progression was carefully collected as a RECIST type of progression, so either a new lesion or increase in tumor burden by more than 20%. And then these patients were randomized in a blinded fashion to regorafenib, 160 milligrams, 3 weeks on or 1 week off, versus placebo. And, you know, there was not a lot of optimism for this study, I would say, because we had 3 other failures before it, as well as the feeling that regorafenib was somewhat similar to sorafenib. Even though in a single-arm phase 2 study before resource, we did see single-agent activity of this drug. And we know this drug is a little different than sorafenib. Rego was approved in colon cancer, where sorafenib did not have activity, as well as we know that Rego is also approved in GI stromal tumors, and sorafenib doesn't have activity there. And needless to say, this was a positive study. It improved survival by about 3 months over placebo. Regorafenib, that translated to a hazard ratio in around this 0.65 range, so it was more than a 30% decrease in the risk of death with regorafenib in this population. There were also concerns about the tolerability of regorafenib, given that in the colon cancer population, regorafenib has toxicities that can make it challenging. But in the liver cancer population, partially because this patient had tolerated prior sorafenib, the toxicity with regorafenib was not too bad. Patients tolerated it. Many patients needed dose delays or dose reduction, but the toxicity was not as bad as expected. And in my experience, it seems even probably better tolerated than in the colorectal population. I think that comes because of our experience with sorafenib and TKIs, and the fact that probably in the colorectal population, patients have had a lot more prior treatments, chemotherapy over a long period of time, whereas in the liver cancer population, it's sorafenib and regorafenib, and the sequence we're seeing is improving survival. We had published an analysis of survival for patients on the resource from start of sorafenib to death on the resource study, and we showed that survival was about 24 months for those patients. So again, this is a subset of patients from clinical trial data, but 24 months is not a number that we've seen in frontline or second-line liver cancer. And this relates to the challenges now in drug development in frontline, right? We're extending survival using the sequence of these new drugs. And regorafenib also met other endpoints, such as improving progression-free survival and time to progression. Response rate is a little higher than sorafenib, but not significantly, and most of the benefit is probably from slowing progression. Another drug approved in the second-line space is cabozantinib. Cabozantinib is a multi-kinase inhibitor, a little different from the others we've talked about in the liver cancer space, in that it not only hits the VEGF receptor, but it hits 2 other kinases, AXL and c-MET. c-MET is the hepatocyte growth factor receptor and has been pursued as a target in liver cancer in and of itself. It's a receptor tyrosine kinase that's very important in the development of hepatocytes. And this drug hits c-MET as an AXL, another oncogenic protein. And this drug was looked at in the second-line setting versus placebo. It was launched after the resource study and subsequently read out sometime after, but showed a very similar result. And what was somewhat different about the design of Celestial is that it also took patients who were sorafenib intolerant, right? That was different than the resource study where they had to tolerate sorafenib. And it also took patients, about 25% of patients in that study had two agents. So they had a third-line population. So sorafenib, another agent, and there were various drugs used, and then they had cabozantinib. So in the intent to treat population, which was the entire true second-line and third-line population, survival was improved by about 2 to 3 months, not too dissimilar from the regorafenib data. The hazard ratio was around 0.78, which is a 22% decrease in the risk of death. And again, like the other kinase inhibitors, it did this without necessarily improving response rates. It slowed progression. If we look at the survival for the truly second-line population and exclude those third-line patients, the hazard ratio drops down to the low 0.7 range. And toxicity with this drug is not too dissimilar from sorafenib and regorafenib. It does have fatigue, GI toxicity, some hand-foot skin reaction, but generally is tolerable and is another option, right? So now we're faced with choices in liver cancer, which is a good thing. It's a good thing for patients and us as treaters. So patients progress on frontline therapy, whether it's sorafenib or lenvatinib. Then they come to second line, and all of these drugs have been studied after prior sorafenib, right? But I think we make the assumption that they're just active in second-line liver cancer. So whether they had lenvatinib frontline, we would still consider either rego or cabozantinib for this population of patients. And, it's a toss-up, I think, which drug you choose. I think for patients who had tolerated sorafenib and did well, it's very logical and evidence-based to go to regorafenib in that sequence, and that 2-year survival data is very provocative. For patients who might have more problems with hypertension or had trouble with sorafenib, then there's probably the data would support using cabozantinib over that. I think ultimately our goal is to sequence things as much as possible, right? And then it means following patients, and there is data using cabozantinib in the third-line setting. So conceivably a sequence of sorafenib, regorafenib, and cabozantinib is evidence-based. The other thing to keep in mind, if patients have an elevated AFP, ramucirumab is also approved in the second-line setting, which we'll probably talk about in a little bit.